Okay, thank you very much. My name is Jim Mulshine, medical oncologist, thoracic medical oncologist from Rush University. And we're going to be talking about cost effectiveness. And to do this, my co-chair is.
Yes, good afternoon, everyone. My name is Harry de Koning. I'm deputy head of the Department of Public Health at Erasmus MC and PI of several of the trials that came along. So Robinska, Nelson, and Four in the Long Run, for instance. But we thought it is opportunity to talk about cost effectiveness. I think so. We will have a short introduction by Kevin and Haaf. But it's good to realize we can, of course, have 3 days on cost effectiveness. You may think, how is that possible? But that is really possible, because I do think that the details that you are talking about in other aspects actually should be talked about also in cost effectiveness. But of course, it's fine. We take an hour or so for now, and maybe I'll invite you for 3 days in the future, maybe.
Yeah.
But thanks. Shall we first ask the panel and or first introduction?
No, just a quick comment. Given the constraint that we have in terms of time and the complexity of the issue, for this, we were kind of focusing on the global issues of cost effectiveness from an international consideration, and what we can manage, what we can't manage, and let's get on with it.
Yes. Shall we maybe ask the individuals to introduce
Yeah.
themselves first, and then
Yes.
two short introductions to the theme?
Hi, Bruce Pyenson. I'm a actuary at the firm in New York City called Milliman. I'm not an economist, although I will be trashing them.
Hi, I'm Kevin ten Haaf. I'm from Erasmus University Medical Center. I'm a data scientist, and I've been involved in lung cancer screening for 13 years, among other things in the CISNET Modeling Consortium, the Nelson, and the Four in the Long Run trial.
I'm Naghavi, founder of HeartLungs.ai. My background is cardiology, and my relation to this panel on cost effectiveness, the work I've done with calcium scoring and getting calcium scoring covered in Texas and now in the United States by Medicare.
Yeah, I have a standing 20 years relationship with those cost effectiveness guys from Erasmus. So I know how to reply to some of those things.
How to be critical? Yes, thanks.
Effectiveness by association.
Yes. Shall we do a short 2 introductions to the theme? Would like to start shortly?
Sure. Cost effectiveness is a reality that we have to deal with, although I believe strongly that the framework that is used with quality adjusted life years has the scientific validity of astrology. Nevertheless, we have to go through an exercise in many countries, and including the United States, to justify and even to fine-tune things that are plainly obvious. So we're in a situation often with cost effectiveness studies of using an embroidery needle to butcher a pig. The healthcare system in the U.S. Kills hundreds of thousands of people with medical errors, and there's all sorts of problems and inefficiencies in the U.S. healthcare system and certainly elsewhere. But the constraints that are put on prevention and early detection are significant and something we have to deal with. In doing that, I believe we have the opportunity to reframe what value actually is for on a societal basis more broadly, and in the sort of things that we're talking about with thoracic screening and connections to cardiac calcification and lung disease as really significant benefits. So I'll I'll stop talking at this point, but I think we were caught in a place where we have to go through the exercise of cost effectiveness in ways that don't make a lot of sense, but at the same time, I think we can reframe value in a much broader and more correct way.
So I have no doubt about the cost effectiveness of lung cancer screening. What I more want to do with these slides is give some background for discussions, basically on how we can implement both stratification and integration in making lung cancer screening and by extent thoracic screening cost effective. And these may seem at odds, but I'll walk you through what I mean. So first of all, what we've seen is that in lung cancer screening, if we use risk prediction models compared to, let's say, pack-year-based criteria, we can both increase sensitivity and specificity. So by stratifying, we can improve efficiency. And the same goes for things like cardiovascular disease. For instance, the SCORE risk prediction model is widely used in Europe. So stratification is also possible for cardiovascular disease. And the good thing about stratification is that it optimizes resource use. So this is an analysis we did for the Swiss Cancer Screening Council. And although annual screening was preferred in Switzerland for a cost-effectiveness measure, they went for biannual screening in part because of resource constraints. Screening with the USPSTF 2021 criteria annually would lead to a 21% increase in CT volume to be able to do that. And that was found to be, well, ineligible. They could go up to, let's say, 20%. So they went for biannual screening. It was found to be cost effective at less than 30,000 euros per life year gained, or quality gained, rather. And if you look at using a, let's say, PLCO M2012 based risk threshold compared to a pack year based threshold, for very, very similar, let's say, qualities gained, you would pay almost 7%, more than 7% lower cost per quality. So stratification does help in, let's say, optimizing your resource use. The drawback of stratification is efficiency versus impact. Now, this table shows the deciles of PLCO M2012 risk in the PLCO and the proportion of cancers per decile. So in the 10th decile, that's where almost 38% of lung cancers occur. Now, if you select the top 30% of risk, you basically cover 75% of lung cancers, which is highly efficient, but this also means that you do miss out on 25% of lung cancers. Now, the question is, with certification, you will at a certain moment have to make a cut of who you include and who not. And what, let's say, measure of efficiency versus impact do we find acceptable? Let's go to integration. What we have heard multiple times over the past day and a half is that the, let's say, risk groups for cardiovascular disease, COPD, and lung cancer cluster. So this is an overview from the Manchester pilot study. And here we can see that with increasing PLCO M2012 risk, the proportion of people with cardiovascular disease and emphysema also increases. So basically, if we target those at highest risk for lung cancer, probably we will also target those at high risk for cardiovascular disease. One thing to do keep in mind, though, is that if you compare imaging to, let's say, the SCORE model that I showed previously, is that actually CAC is a better tool for risk stratification than, let's say, a general risk score without it. So one could also argue that maybe we can use the screening to stratify cardiovascular risk rather than let's say, select people on their pre-screening cardiovascular risk. And one thing we've seen from Rubinska is that if we compare who is, let's say, indicated for preventive drug treatment for cardiovascular disease, is that there's basically over-treatment in the arm that is assessed by the SCORE model, Well, if you use CAC scoring, less people are indicated for preventive drug treatment. So in this case, this integrated certification, as I may call it, may actually reduce overtreatment. Another thing to consider is integrating primary prevention. This is from a recent study from my PhD student who looked at the effect of biannual interventions for smoking cessation compared to screening and integrating screening with smoking cessation. Now, this is done in a population that's eligible for the 4 in the long run trial, but over 50% of these individuals have already quit smoking. So for them, basically, a one-time screen would actually yield more life years gained than a cessation, let's say, continuous cessation intervention. However, if you combine the two, you can increase the, let's say, life years gained from CT screening by up to 25%. Now, the question, of course, is this is for lung cancer in particular, but the question is, how does this look for, let's say, cardiovascular screening or for COPD screening? That is an important question we still need to answer. Finally, let's talk about budget impact. This is the budget impact from the Swiss cancer screening study I showed earlier. And what you see here is that basically your budget impact is front-loaded. First, you send out invitations, which cost money. And due to lead time, you basically drag cases forward. So their treatment costs are also pulled forward. So in the first few years of the program, you will make a lot of costs. However, by the time you start preventing, especially their terminal care phase, you start to see cost savings in the terminal care aspect. And keep in mind, these are numbers before immunotherapy use was widespread. So this will probably be more beneficial even, let's say, in the longer term. And what you can see here is that the CT scans, after, let's say, 5 to 10 years, make up about 55% of your CT program cost. However, if you look at the cost savings from preventing terminal care for lung cancer, that basically pays for your CT scans. And if we combine this with, let's say, cardiovascular screening or COPD screening, basically, if we use the same CT scan for both and also prevent care costs for those, perhaps we could even go to, let's say, very, very low cost effectiveness or even cost-saving interventions. So I want to give this as an introduction to basically discuss with you all how to best combine certification and integration, even though they are seemingly at odds. Certification improves efficiency and resource requirements and cost effectiveness, which is required by some countries simply due to certain limitations. It does come at a loss of impact. So what is an acceptable trade-off? That is something we should discuss. Finally, integration can also optimize resource use and effectiveness. And especially if we consider that the CT scans are a major component, cost component of screening. So combining different screenings within the same CT scan can drastically reduce your budget impact. Although there the question is integrated programs, they are very helpful, but they're also much more challenging to implement, evaluate, and maintain. And I think we all want to implement like integrated programs, but we should think carefully on how to facilitate their implementation. And I'd be very happy to go into discussion with that.
This is an excellent introduction from coming from different methodologies and highlighting that, you know, this is a complex issue. So what we have is we have a series of questions as we will proceed in the process described yesterday by Dr. Jankelowitz. So the first key question is, and this is again a conceptual question, not a precise question. What is the cost benefit of leveraging annual lung cancer screening to also manage other tobacco-related diseases such as emphysema, COPD, and coronary artery disease in a responsible fashion? Now, the reason we're discussing this is there might be pushback about complexity, but the mitigating factor is in the United States where screening is done, in a number of other international contexts where screening is done, they're functionally already doing all three. And they've figured out different paths to solution. And the interesting thing would be to kind of extract the best practices from that to kind of advance the process. And the tail end of this question is also, since it's a global pandemic of tobacco related diseases, how do we kind of cooperate to move through this transition period into integrated screening in a, satisfactory, responsible, hopefully beneficial way? So we'll if it's okay, we're not revolutionary, so we'll start from the right and move to the left.
Right? Right?
You're on,
That-
Bruce.
Right.
Thank you.
So I think the one of the challenges we have is the silo approach to health economics or clinical efficacy that David Yankelevich mentioned yesterday. So we have obviously the technology works and the demonstration of the effectiveness for cardiac calcification detection and the effect for COPD detection and others has been known for several years. But what we're facing a situation where the early detection of COPD is not even recommended. There's no recommended screening for COPD in the United States. So we have we really need a new framework for demonstrating the effectiveness here, and it has to start from a population basis rather than a disease basis. So I think the tobacco affected population in the U.S. is the place to start, and probably Europe. It's probably a different population basis to start in Taiwan, in the Asian populations, as we heard yesterday. So I think that's a way to frame this differently. I'm not sure if I answered your question.
No, I think so. I think that we're gonna get a composite, but you're hitting pretty close if you didn't directly answer it. Kevin?
Yeah, I think the challenging thing is the implementation aspect, which my view on this is that one thing to ease, let's say, this challenge of implementation is if we embed this in a lung cancer screening framework where it's also easier to implement if you start with the high-risk group, because that's where you start to see your benefits, let's say, quicker, which will be more convincing in the implementation phase. And then from that, with the, let's say, downgoing tobacco epidemic, slowly stratify from being lung cancer screening with other thoracic diseases added, from being, let's say, a population-based thoracic screening approach that may search for lung cancer in high-risk individuals. I think that is probably the way to go. I think the results from Rubinska showing, let's say, that you can reduce preventative treatment, let's say, reduce over-treatment and thus costs, would go a long way in helping to convince policymakers in going for this approach.
Yes, I appreciate that. The one mitigating factor is that COPD emphysema is a risk factor for both lung cancer and death. And if you have the screening information on that, and it is a well-documented, predictive biomarker, you have to tell them about it. And then you start telling them about it and they say, well, what are you going to do about that? I mean, it is a tobacco-related disease, and you get pulled into the fact that these are comorbid conditions that we've known about for generations. And so it's a very complex challenge. Mort?
I would like to make it uncomplex by taking tobacco out, and let's just talk about what you said, thoracic screening. I think with this approach, what we call heart-lung, which is more than just heart and lung, I showed you we have 10 actionable reports that come out from the same thing. And the fact that we have cardiologists, radiologists, pulmonologists here united by one chest CT scan. I think we have, for the first time, an opportunity to introduce a test that is not only cost effective, but actually cost saving. And here's why. So everything you know and you guys have built on lung cancer screening in Europe, add to it coronary artery disease, add to it cardiac chambers volumetry for heart failure, stroke, atrial fibrillation. These three are about 50% of burden of cardiovascular disease. The other 50% is coronary artery disease. Okay, so CAC is one side, chambers, AFib, a stroke, which is also linked to thoracic calcification. So the more calcification in thoracic wall, aortic thoracic wall, the higher your risk of stroke. So put all of these in one basket. Of course, you have your lung nodule. Then, of course, emphysema. I disagree that we should, ignore emphysema or thinks that this is like, we can't touch it. I circulated a paper from Graham Barr that showed in Mesa, those patients who were emphysematous or had high emphysema score at baseline, who were on aspirin, just aspirin, baby aspirin in Mesa, had 50% less incidence of COPD 10 years later. So, and we all know it's an inflammatory disease. And people like Javier and colleagues are working on it, or at least calling for it. And hopefully we will be part of it, this I-ELCAP group be part of it to move the needle down that path. Then go a little bit back to the chest where you have this vertebral bodies. As I showed yesterday, you measure bone density and you identify osteopenia and osteoporosis, which is by far the most cost-effective test screening for osteoporosis approved by U.S. Preventive Task Force Services 20 years ago. As you know how hard it is to get something through them. They realized that after age 30, we all have, men lose testosterone, even women lose some part of their natural testosterone and go on the downhill for losing bone density. Some go on a faster track. If you're able to detect them, flag them, we have good treatments. In fact, the treatment that we have in osteoporosis and osteopenia is better than cardiovascular and lung cancer because it works. You have injection every 6 months. So, and then come down a little bit, you get the fatty liver. We do have people, and I had some cases to show you that their calcium is 0, their lipid panel is normal, they're not overweight, they have a huge high fat liver percentage. I showed an example in our meeting at Mount Sinai 2 weeks ago. So we identify those, we give them a Z-score style where, say, compared to people your age, your gender, your weight, on the right side or wrong side, and we trigger actions. We do have, as I said, actionable report, not things that we can't do anything about it. For calcium score, we know what to do. For enlarged LA and LV, we are building, because this is pretty new from, not contrast scans, we're building plans for it. But we know you have to treat hypertension. If you have enlarged LV, you have to double treat, hypertension. You be really strict about lowering, those risk factors. So I think we opened the door to a really unique test that never existed in medicine, because medicine was just all tunnel looking in one thing. But we have the ability to bring this, multidisciplinary group under one umbrella of United Chest CT, and we get to the bottom of this and put it together. I think the I-ELCAP leadership is key to bring this, and because they've been doing that. Like Claudia and David been doing it qualitatively, but I think we now have the ability, plus add to it AI. I mean, AI is just facilitator. It makes it cheaper, easier, less human, cost, but you can put this together. I envision like 5 years or so, we would go to Medicare with the help of his friendly economist and Bruce, put forward a real solid case that if you do this, if you do a screening, hard lung screening from here to here, with addressing the radiation, you actually save cost besides saving life. It's not cost effective, it actually saves money and brings money back to the system.
Okay, thank you, Mort. And that's an option, and it may be an option that's easier to pursue in other international settings than in, you know, our U.S. Preventive Services Task Force and would other policy-driven type of environment. But it's an incredible opportunity, and the question is, how do we kind of sequence it in the most efficient fashion? Matthias?
Yeah, my position is a little bit less opportunistic and optimistic. So that those are both different things, as you know. I think we have inevitable problems here. So I think there's no way around to address those things that are proven and that are in the data. So we have a proven track record on coronary artery disease. It took, by the way, 20 years at least before coronary calcium was in the guidelines. But you need this proof that it is really sensible to come with these reports. Because the big danger here is that we are coming in the range of just imaging aging. And that is not really what we would like to do. So if we would like to really focus on why we stepped in this profession, indeed to help the sick patient, and according to the Hippocratic Oath, then we should not just go for the opportunities. It should be related to a kind of ethical relation. And from that perspective, I think we lack the data on what is normal aging. So I had a discussion with a cardiologist with a guy that was 80 years old and had several stenosis in the left coronary artery, but there was no impact of the stenosis. The perfusion of the myocardium was fully okay, and also the stress MRI test, you had no inducible ischemic parts in the ventricle. So there was not really a reason to do anything in his left in his LAD. And then the cardiologist said, and that tells the whole story, he should have the same coronaries as he were 20. So we are going to do a complete anatomical reconstruction. So I think that's nuts. And hearing you,
A licensed cardiologist?
yeah. No. The opposite is you have in Moscow this huge cardio clinic with 500 beds, and there they did everything that you could imagine. And so they would, from Brezhnev to Putin, they would treat them in this hospital. So a lot of knowledge there. And they had a showcase. And that showcase, they showed me in one patient, 35 stents. And they told me, this is a fantastic case. It really had a reimbursement per stent. That's what he had in Moscow. So that's probably different from the West. One case, $50,000. Fantastic. Now, that's really the medicine that we do not want. So what we are looking for is a real sensible approach to what is in the data. And there's a lot in the data. And I think indeed it could be in the future that we could reliably identify all those chambers and also come first with the muscle mass. That's probably to do, and it's very informative. So we should focus on developing reliable image biomarkers. Now, we had a white paper from Mulshine on emphysema, and we had already a discussion that we would like to deal with COPD, but COPD in the definition has the word obstructive. So that's a functional test. And a functional test, we do not do this. We do not do in an exploration in our screening implementation for lung cancer screening. So therefore, we should really stick to what we are doing. And so we have to develop a reliable biomarker for emphysema. And that's not so easy. So we are working on this. Noise is an extremely difficult issue there. And it took us now about 15 years, 20 years to get a reliable biomarker. And then you have to really test it in, as Rika Villa also very much supports that it's that you have a system that can reliable measure the calcium score. So it all depends what you can do on the development of the imaging biomarkers by CT. And if you have proven, and Alec Casaruni wants proof. Now she's right. So we have to prove each imaging biomarker to make decisions on before we can do any implementation. Now, the scary thing about this whole stuff is that we see all kinds of opportunities at the moment. We are going to report all kinds of things that are not proven without any image biomarker validation. And then we are just reporting things that are related to aging. It's already difficult. So we have a normal aging of the coronaries. So in women, the aging of the coronaries is 10 years behind that of the man. You have to notice. So they're charged to really know what is a normal development of aging. And also, if you come over a certain threshold of coronary calcification, you come in a region that you don't get any infarcts anymore. So there is a lot of background needed before you come to the right interpretation of all those data that are indeed in this volume that we measure. So therefore, I think all the opportunities are there, but if they are valid, that's a completely different issue. And I think we have our hands full with the three that we now defined. That is the lung cancer, the nodules, the calcium score, and also the emphysema. And I think that is already work for the coming 5 to 10 years, making that reliable. And if we also go now on osteoporosis, I think it saves lives also, osteoporosis.
That's already more valid than
Oh, it's
all
more
the
valid.
three,
No.
because that's already part of the preventive screening test.
So if I may interrupt indeed. So I thought indeed the summary would be that the whole panel is in favor of adding additional disease screening, let's say in the CT scanning. Indeed, the chest CT now is exceptional in all the screening history, etc. The chest CT now is exceptional. But let's say the argument made here is that yes, very interesting, but we have to be completely sure for each of the individual diseases that we would like to add. I think that is, I'm not sure whether I'm summarizing that correctly. And of course, either we could disagree or whatever, but
I think we agree, but there is perhaps differences in how to consider the separate diseases as standalone or as part of a package. And that is an issue for perhaps, how the regulatory agencies think about things and how we construct the model of outcomes. And if part of that, so I think we agree on.
Yes, I do think so too. The only thing is indeed, Matthijs basically, I think, says, listen, with the three, there are these first two, there are already so many issues that we have to cover in the next 5 to 10 years or so that he isn't sure we should do number 4 or 5. But yes,
we all have to follow evidence.
Yes.
There's no,
yes,
except the
No,
Russian style.
yes,
We'll
Yes,
just
we don't-
leave
we're
that
not-
out.
yeah.
But
That's also the US style, by the way.
the US style is evidence. You have the evidence, you go. I'm one of those that have been fighting with US Preventive Task Force Services. It's because I could not generate the evidence because it's unethical to do a controlled trial for a coronary calcium score. And that's what you need to have for evidence. So in terms of the items that Matthias said, we do have evidence, more evidence for osteoporosis, a strong evidence for calcium scoring, partial evidence for emphysema that needs to be built, of course, solid evidence for lung nodules screening. But if this room, in a big room just like this is for NASH, for those alcoholic steatosis in liver. And the same people argue that once you found fatty liver, you got to do something. You can't just close your eyes
Yes, yes.
and don't tell anything to that patient, especially the patient is not on GLP-1, not on, a lipid lowering. So it's ethical to do this. It would be unethical to not say. What do we do that? There is a standard protocol for that, and that they have used part of the liver and have extrapolated. So that's a good question to answer. Whether there is a second step. This would be a screening, and you find very high Z-score of fatty liver, send them to the next step that they do in their guidelines. But just closing your eyes and saying this is too opportunistic, I want to be too ethical. I mean, it just doesn't make sense. Because we have other people just like this that are passionate about lung cancer, they're passionate for fatty liver, and they have done their homework. So I think that we are really creating a unique opportunity that never existed before with CT coming from, top down and AI doing most of the work. And then we just have the responsibility to bring the evidence and the people together and create a consensus.
Thanks. I like to see whether there are questions from the floor on specifically this here of adding tobacco related. Let's start with adding tobacco related diseases to your lung nodule algorithms on the one hand, and you even say, let's maybe even skip tobacco related. Yeah, please.
So I have a problem, and I'm all for as a pulmonologist detecting COPD early,
Yeah.
but we don't even know what that means, right? So no, we don't really know what the natural history of COPD is. So if we detect early COPD, we have a problem. In the screening population, there's overdiagnosis of COPD with spirometry. So we know the older patients tend to have FEV1 FEC ratios under 70%. That doesn't mean that they have disease. It might just mean that they're aging. So there's all these concerns as to if we identify COPD in this group of people, what does that mean and what is actionable? And honestly, as pulmonologists, we usually use it to encourage people to stop smoking. That's really why I look for COPD in my screenees, and I tell them, look, your lung function is not normal, so you really need to quit smoking. And, treating them, we don't know if that helps in the long run in terms of preventing lung function decline. We don't know if it prevents lung function decline that's clinically relevant, and we don't know if it prevents exacerbations, which is really what the treatment is for COPD about. So it's a complicated issue that goes beyond, can we identify it?
Yes, thanks very much. Very helpful, because indeed this is certainly one of the big debates. Or the moment you have the diagnosis, what can we do? So far, indeed, you say I'm for instance telling them what they are having and what they maybe didn't know yet. But as you know, there are some trials that try to give this kind of either the CT scoring or the image or whatever. And again, the result is sort of indeterminate whether it helps in stopping with smoking, for instance. Even so, even there is an issue. But anyhow, thanks.
Can I just make a comment?
Yeah, sure.
This is about a conversation with this community.
Yes.
Now,
Yeah.
we've been talking about the interventions that are possible within the emphysema COPD spectrum. And, in cardiovascular disease, we have things like exercise, which turns out to be quite efficacious. It's low cost point, low morbidity, and effective. Half of the deaths in COPD emphysema spectrum are due to cardiovascular disease. And we have not a single study of exercise in this asymptomatic setting. And so it's not a question of good or bad, truth or what, we don't even know anything. And it would not be hard for any one of 20 sites in this room to start doing, some kinds of evaluation, to start looking at some preventive measures, antibiotic interventions, exercise, very simple things that are relatively cost effective when proven, that we should not be paralyzed. And there's all kinds of other aspects of interventions that we could get our colleagues to do with diet and stuff up and down the line relative to fatty liver disease and a whole variety of other things. So I think it is a unique opportunity, but we have to think out of the box. Claudia?
From the very, from early on, we said we had to report on all the findings on CT, and we reached out to each of the specialty or disciplines to make recommendations. We make recommendations for each and every finding that's abnormal. So first of all, we decided what was normal and abnormal. And so we've reported on the fatty liver for a long time. And there are, I think there is an obligation to give that report and to figure out what the recommendations are. So I think that to not report, and I think we should report on all of them.
So of course, again, we can have a half day on this, of course, but indeed, it's on the one hand very, very good that that you first of all, of course, define clearly what is abnormal and normal, and indeed give a clear-cut, let's say, recommendation that goes with that. But just to give a bit the other side, so as an example for the Netherlands, for instance, our Health Council of the Netherlands, maybe a sort of US Preventive Services Task Force, but they explicitly said you are only allowed to report findings that we know will impact the prognosis of the individual. Just to give you a bit the other side. So indeed, I can fully understand.
A government organization.
A government organization with experts and medical doctors in it and ethicists or whatever. But indeed, a kind of US Preventive Task Force that is sort of maybe maybe you could say on the complete other side. If I don't know, if I don't find enough evidence, I'm not going to say yes to it. So, but nevertheless, I'm just saying that in the next 5 or 10 years, we have to indeed, this collaboration would be key to see how countries work, and indeed, if there are countries enough that say calcium scoring is clear cut, how should we then do that? So I'm just in favor of
We
that.
have easy answer. You are
No.
over 100, you need to get treated. And treatment is not another nuclear scan or another CAT scan. You just need to go get on statin.
But
So
I
proper-
agree. But indeed, again, the next step in many instances is, for instance, a GP or so, or a primary care doctor, and they will not all go to cardiologists. And we have had situations in which we got a call of the individual, of the patient, let's say, that said to whom we said you have a calcium score of 700 or 1,000, and that the GP said, I don't know what to do. And so anyhow, it's not good, but nevertheless. So just to give, I think what I said, there is still a lot of work to do to get it right. Let's say maybe would be my summary. To get it right for the individuals and for the country or public health, because that's my work.
Question.
But anyhow, yes.
I think a gap in our knowledge, and maybe this is perhaps pretty easy to solve, is the undiagnosed people who are newly discovered through screening.
Yeah.
And because in many cases, people, are already on statin treatment or so forth. So having the information on what's the increment in the population now, that's still, as we said, well, what do you do about it? Is there a benefit? But just getting the numbers, I think
Yes.
we probably have that pretty readily available in
Yes.
Has that been published already?
75% of people found to have emphysema on CT scanning, screening, and several series. I have no idea.
No.
Okay, do we know?
If you didn't hear that, yes, I will come to you. So if you didn't hear it, 75% of individuals did with let's say the definition of emphysema did not know they have it. That's what some of the reports comes. Yeah, I think there was a question over there. Yeah.
I just wanted to let you know that we published like 3 or 4 years ago a paper where we analyzed the ACRIN database that included spirometry in the LST. That 18,000 people had a spirometry. 75% of them had obstructive airway disease. Half of them were having symptoms, were not treated, they did not know that have a COPD. I'm coming from the COPD world, from the perspective of the world guidelines. They need to be treated, they have indication to be treated. So then they have another reason for why we should screen for COPD in lung cancer screening program. And the second one is that they have a higher risk for lung cancer, so they should stay in the lung cancer screening program for their entire life. And if they have also added emphysema, their risk increased to 3 or 4 times. So all this worth of information is needed to restructure our lung cancer screening programs.
Thank you. Thank you very much. So indeed, you say maybe the emphysema score, or let's say the emphysema score, should maybe even take into account for the screening interval or the new risk assessment, maybe. It's an open question which we're not probably not going to address now. And the other, I must say, interesting thing is, why are we not adding something like physical exercise? Because we're often still thinking about the tobacco and the tobacco cessation, of course, which is really, really good, of course. Let's be clear about that. But other interventions that that might be beneficial actually also in this risk cohort, I think I indeed have not heard yet. So I think this is also interesting and a lot of work to be done still. Let's give it time, maybe change the scene a little bit. So cost effectiveness, I would think the whole panel thinks that lung cancer screening is cost effective. Adding maybe more screenings could even become cost saving. But we have, of course, not all resources in every country. We have capacity issues. So how can we incorporate that in cost effectiveness analysis, or how can we be sure that that the resources are spent well, or that the capacity is possible in the next 5 to 10 years or so? Is that a bit clear what I would like to ask the panel?
The biggest risk in thoracic screening is the initial scan. The follow-up treatment or follow-up diagnostics are relatively small. So to make things more cost effective, reduce the price of the scan. And I think the imperative here is to use software to reduce the cost, or else find other ways to reduce the cost. But since we have more efficiency coming through AI and software, that's the way to do it. So I think it's a very simple issue. No, I don't want to disrespect Kevin, about finding the most efficiency, but I think you can only push that so far.
Well, that depends a bit on the country themselves. AI will, let's say, make the reading of scans. It will cut down on workload there, but then the question is, does the country have sufficient CT machines or even radiologists just to evaluate the other scans? Let's say that's also the case. I want to talk about something else with regards to resources that is not as often mentioned, but is a key component of getting a functional lung cancer screening program, is thoracic surgeon capacity. Because if we can get sufficient numbers of individuals, then the number of individuals that will, instead of being treated with radiotherapy or immunotherapy or chemotherapy, they will all go for surgery, and we will see a massive increase in people that can happily undergo surgery, provided that there is enough surgical capacity in a country. So I'll say, if we're talking about resources, we shouldn't only look at, let's say, the resources for the screening program, but also for the entirety of the follow-up until, let's say, we can happily send the patient home, hopefully cured. So any country that is willing to look into building capacity, also have a look at your expected, let's say, surgical capacity, to make sure that those that you detect, that you can actually treat them, and that you don't have a treatment delay saying like, okay, we detected your lung cancer, but the next surgery slot is in, let's say, 6 months.
Thanks.
Yeah, I think resources will follow, you know, they all saying you fill the field, they will come. Once you have identified a large volume of people and you start by placing proper follow-up so they don't just get, because no screening test saves lives. It's the intervention after that that saves lives. Everybody needs to understand that.
Yes.
And once you put a
Yes.
system in place for that, then resources will follow. So I mean, if APA was just to build 100 of these, this would have been $50,000 or $1 million one, right? Once they build millions of these, we can afford it. So the volume, I mean, you know the economy of the volume. So the volume will follow up. Will follow up once we build this. We just need to build it, make it reliable, ethical. Everybody buys into it, evidence-based. I think the resources will follow, and the resources will follow because it saves lives and it saves costs. So, everybody will win. But I agree that maybe the first year, it may have some, bottlenecks that you will have to work it out.
I agree, but some things, just to intervene, some things can only be scaled up so quickly. Implementing AI can be done relatively quickly, but training a thoracic surgeon, that, at least to my knowledge, you don't train them within a year.
But it presents opportunities for entrepreneurs to come up with new solutions. So, I mean, that's how we evolve in medicine and anything else. Once we create, but because we have grand goal, and the goal is, for example, today we're at 90% gap of screening, meaning 10% of people with lung cancer are detected by a screen, the rest of them by symptoms. In cardiology, we're not better than that. Majority, maybe 90 plus, are detected by chest pain when they come to chest. That's why we have 12 million chest pain, every year. 10 to 12 million chest pain in the US, 1 to 1.5 are cardiovascular. So a lot of people come to our system. So these are all resource sucking because we don't have a proper system in place. Once we put the proper system in place and stop this overstenting or over treatments and so on with proper guidelines, I think the resources will adjust and follow through.
Matthijs?
Yeah, I think you should do a better job. I think it is already cost effective. So you should take into account what the difference in the percentages of the stage shift, the stage 4, which is going down by 20, 30, 40%. And the cost saving of the downgrade of the stage shift is huge. And if you can really couple this to all you do in cost effectiveness at the forefront, you should also do it on the effectiveness at the back end. And if you make that to one cost effectiveness analysis, then it will be extremely cost effective. I think it will be more than 50% cost savings if you implement this early detection. So you should do a better job. And I think you should do it because no one else is going to do it.
Thanks. Yes, I know.
Harry,
Thanks
no
from the
pressure.
board. No. So that's good. I did want to go to the creation group actually to ask whether you have noticed any capacity issues in the treatment setting, for instance. Would you? Yeah, maybe I come to you.
Thank you all for a really interesting discussion. I enjoyed all the time in all the fights between you. Okay. I will try to give you a few answers regarding the additional treatment burden, which is obvious as a part of the screening program. After 3 years, we increased the number of thoracic surgery procedures to 20%, only after 3 years. We are pretty sure that we will increase that 50 or probably 100% in the next 3 years. But of course, we have to take that into the account and to make a plan how to overcome that problem. There is no problem with that. In fact, what was the second question?
That was the most important one to me.
Okay.
Otherwise, I come back to you.
Yeah. Regarding the cost-effective analysis, we try to make that preliminary data before the national program was that the cost of the expensive therapy, including the immunotherapy, will go down 5 or 6 times after 5 years. It is obvious case how we will save the money for the healthcare system.
Thanks. There were enough questions indeed. Let's go. You first.
I think
One thing you have to worry about with the cost effectiveness is what we were talking about earlier with your negative surgery rate. That's going to be an expense. I couldn't hear what you were saying. I wasn't sure if that's what you were talking about, but you need to take that into account. If your surgery rate for benign disease is 20%, that may not be cost effective. So it depends. If you've got to bring that down to 2 to 3%. So that's going to be another measure of success of your screening program.
Yeah, thanks. Has to be included indeed. Yeah. Question over there.
Yeah, it's
Uh,
more
uh,
of a comment.
Maybe. Oh, the microphone's coming. Yes.
Yes, thank you. It's more of a comment. I mean, from the affordability side of things. So we did a session yesterday where some of the African challenges were pointed out. Now, the average center in Africa would have a 16 slice and above. You can do calcium scoring with that, but you can't connect AI to it. So we're probably not going to be talking about AI as a cost saving for that sort of environment. So you still need to do your cost, manual calcium scoring. You pick up nodules, and in terms of nodule management, we've got the long rads to kind of guide what we could do. And of course, we talked a lot about the discussions about the clinical of the conversation with the pulmonologist as to what the best approach is. It's still not agreed whether you take these nodules out or you biopsy them or you watch them. So I think to be more global in the conversation, the concept of saying that AI would solve the problem may not actually be applicable to the entire, all the continents, because I think there'll be technology challenges. We saw a lot of data from photon counting CT. I don't know when that sort of technology is going to get to that neck of the woods. So I think we still have something that works, even though it sounds a bit crude because it's a 16 slice scanner, but it still does a great, a good job of being able to spot emphysema, being able to spot coronary calcium, being able to also spot nodules. And I think that part of the conversation needs to be part of the global conversation.
Can I comment on the AI
Yes.
part? All the data that I showed you yesterday, some of them I didn't get to show you. They were all from MESA 1, done in 2000, 2002, EBCT, and 4 to 8 slice CT. All of our AI results, predicting AFib, heart failure, a stroke, and of course, calcium score. They were all done based on that. And we are building this with the intention of going to United Nations for India, China, Africa. The cost only AI can bring the cost down, that India can use it, at $10, or Africa can do that. So everything that we showed yesterday with all of those 10 items were done on very basic machines, nothing like photo counting CT or anything fancy, and you can scale it.
Thanks.
No,
So
Let's do another fight.
yeah, I'm not sure whether. Yeah,
EBT
sure.
is-
That's good.
EBT is not a low cost.
No, it's not.
system. It's a very high-end system.
It's
And at that
extinct,
time,
too.
even the temporal resolution of the EBT in that time is better than the fastest CT at
Yeah.
this moment.
If EBT,
You can, for cardiac, you cannot
Yeah, if-
compare anything to EBT.
EBT was half of MESA
Yeah,
1.
yeah. So in MESA, 80% is EBT.
Half were.
Half, okay, but a
Okay.
lot of them,
Let-
and if you do that on that data, you have high quality data for the
Let-
cardiac.
let
Cannot be better.
Let me say, EBT lacks a spatial resolution. You couldn't go below 3 millimeters. That's how it was. Yeah, it's not Rick, it's physics.
It's physics, but they can tell you that the spatial resolution is completely hampered by the temporal resolution.
Right, but we're
So
talking.
therefore, the temporal resolution is the key to really keep your spatial resolution when you go down to beyond the 100 milliseconds.
We cut this debate here.
This
I
is-
think
that's
it's
it.
clear-cut.
But I'm just saying, don't worry about it. These things that we showed you were
I
all
think
basic machines.
I think that somebody should be worry about it. I think what I'm hearing in the I mean what we are all
Why do you have to worry when you have data?
in the sense that we are all saying I mean, before we went all this, we all thought in the plane, we thought, okay, we are going for screening, but of course only at the highest quality or something like that. And the quality means also the follow-up. You were talking about we're still not completely sure what we should do with the low nodules. And of course, the treatment afterwards. Again, if that doesn't work, or if the primary care doctor is not referring the individual, we are screwed. So I'm just talking about high quality.
On that,
but
I mean, calcium score works on those machines.
Oh, okay, okay, okay.
Technically it does. Okay, Jim, there you go.
Please. The occupant Kalavet's last word, better be brief.
I was a little, I don't want to quite say the word struck, but it was interesting to me that our colleague from Africa said that they're using, for example, lung rags. And Carrie, you and I had this discussion about screening and protocols. And it seems to me that you can make, why not change the protocols? Why not understand the resources available? You're not going to be able to chase down every 4mm nodule. You may not be able to screen every year, but you can still do what's going to fit for that country and for their resources. And I think we need to be thinking more in terms of country-specific protocols.
Thanks, David. That's I think, I'm not sure whether we still have time, but I think that's a perfect summary indeed. To me, as Matthijs said, he's working with these guys on cost effectiveness for years and years. Whether it's 3,000 or 6,000 or 10,000 or it's cost saving, that number itself really says a little bit, but it's in the details. And indeed you probably have to make an analysis, well, almost for each individual country or situation or region, and then you get into issues of, okay, given the resources, this and that is probably the best thing to do, or this and that we can make the highest quality or whatever. So thanks, David. I think that is a nice summary.
Okay,
of
so we have
cost
12 minutes
effectiveness.
left.
But
With 12 minutes left.
Yeah.
And we're going to explore a little less tempestuous topic. And that is, if we are allowed to do tobacco-related diseases, we have a unitary benefit related to cessation. And the one thing that policy groups across the globe have appreciated is how cost-effective smoking cessation can be. And we know it's not a total answer and that early detection is very complementary. But given the opportunity for smoking cessation have differential benefits, may not be so great as Dr. Yankelis was saying in terms of lung cancer risk, but it may be very important in terms of arresting or not, allowing no further progression of COPD injury, parenchymal injury, cardiovascular risk, and stuff like that. Given that, how do we put together whatever we're going to do in early detection to ensure that there's no distance between the efforts to affect smoking cessation along with more effective, even multi-disease early detection? And so, Bruce, you want to start out? You've published on this, and so
Yeah.
I appreciate your comments.
Well, smoking cessation is of course highly cost effective, and the evidence is that pharmaceutical support makes it more effective, and the pharmaceuticals these days are all generics and very inexpensive. But I think the context for implementing this it has to be demedicalized. And as with screening and other issues, I think we're missing an opportunity to bring to a public health environment all of the related issues. Demedicalizing, I think, will solve a lot of the issues. And I'll use the comparison. Who do we have? We train people to how to drive cars, and that's a public health, if you will, public safety issue. And I don't think there's a single country that has collision repair experts teaching driver's ed. So why do we do that for things like smoking, smoking cessation and screening? it creates too much complexity and distorts financial incentives and all sorts of other things. So I think that's my view of making that effective. We're missing an opportunity.
Okay, thank you. Kevin?
Yeah, I think integrating smoking cessation in, let's say, a navigator context would be most appropriate. This would work on a number of things. Especially, we've seen abysmal uptakes, for instance, in the US, but we have seen that uptake and adherence to screening with the use of a navigator definitely improves. And if we want to have an effective and to be cost effective, we first need an effective screening program. To have an effective screening program, we need to have, let's say, a decent level of adherence. If we already need a navigator to basically establish that, having someone who is also, let's say, a go-to person who is trusted by the participant to also facilitate their smoking cessation, we have seen in pilot studies that really helps. And I think that would further increase the cost effectiveness of screening by integrating that in a navigator structure.
Thank you. Very concrete suggestion. Thank you. Mort?
I would just consider it really a fundamental problem in the society. You know, what percentage of smokers don't know that what they're doing is wrong? Probably close to zero. It's the same thing with weight. You know, what percent of overweight people don't know that overweight is bad? It's just behavioral, change is not easy. I think as physicians and scientists, our job is to come up with more than just advise to stop smoking or so. We come up with solutions, just like GLP-1 made kind of a magic. So I don't have any easy answer. This is not field, but in our field, about 50% of patients, smokers post-MI, continue to smoke.
Yeah.
I mean, what drastic shock you can get more than an MI and being on, bed in ICU and so on. So I think we just have to be more realistic and look at ourselves, especially me, like I got some extra pound. And so how do you treat, obesity and overweight?
Yeah.
And the same thing you would look at other behavioral things.
Yeah, More, I think your points are very important. However, NCI did fund 9 R01s to look at tailoring smoking cessation to the setting of screening, to say, we're going to go beyond giving you a hotline. We're going to do this, that, the other thing. We're going to look at the failures and try to figure out for people that are not, adherent, does progression to drugs help? And there's a very significant literature about this. So it's just putting it.
The answer is yes, right?
Yes, it does. Yes,
So pharmacologics.
So we have to graduate these things and keep it up. And screening, we're just tied up with the beginning of screening. The next 25 years, there's an opportunity for lots of other things in terms of coaching and efforts to enhance health behaviors. Final word.
Yeah, I think the coupling is very cumbersome because the screening participant who stops with smoking will have no benefit from it. He still has to be in the program because he smoked already for 30 years. So he has no benefit of stopping smoking. So what the heck to implement it and couple it to screening? I don't understand the whole system. So smoking cessation is crucial, but not for the people that are in the screening program. So the coupling is nonsense.
I vehemently disagree on that.
So much for consensus. Yes. Okay. Harry, did you want to comment on that?
I think I don't know Matthijs, but I think he's to some extent quoting our recent paper indeed that Kevin also showed from our PhD students who indeed show that, and we deliberately gave that message to the press to say, indeed, listen up. People at such high risk that are eligible for a CT screening program and are still smoking, they probably have tried enormously already. Well, not maybe everyone, but many have tried, of course, and fail. And the first thing they should do is go to the CT screening, indeed. And indeed, even after the baseline scan being negative, he or she should indeed have another scan in some point of time. So Matthijs is exaggerating a little bit, but that's what he's basically, I think, saying that, yeah, we should be clear about that at least. And so, all know the politics around and why do a CT scanning if they could quit smoking. Well, we actually see that indeed, surely we would like to have everyone quit smoking, but at the same time, they should at least go for the CT scanning. So that would certainly still also be my last words.
I appreciate that. But in terms of impact of smoking cessation on cardiovascular disease
Yes,
and COPD emphysema,
yes.
it's a different kettle of fish. So from an integrated screening perspective, so smoking cessation has residual benefits across the board.
Yes.
But the thing I would say from a global perspective, listening to the presentations last night, is that in Africa, where there's not as much uptake of tobacco consumption as in other parts of the world, we have to make some effort that if we can short circuit this epidemic to a degree in Africa by making it very clear the marketing efforts of the major tobacco companies in that setting is just, tragic. And that we should, kind of underscore that tobacco control in places where tobacco is not critical in terms of lung cancer, and that's really hard to say on this planet, but we heard some very passionate remarks about Colombia and the impact of tobacco in Colombia. We've heard about the rising impact of air pollution and other factors causing lung cancer. We have to be sensitive to these things, but by the same token, it is the leading single killer on our planet. So we have some responsibility. Other final comments in this regard? We have a whole 120 seconds. Fred.
Yeah, I would be interested in hearing Raja answer the question that was asked earlier, whether there's sufficient manpower to deal with lung cancer. And if he would do it for the United States, perhaps someone else would do it for
Fred,
Spain
I think
and
you
all.
meant person power. I'm speaking for the female thoracic surgeons of the world.
Absolutely, Jim. Thank you.
It was a tight one, but. Okay, Raja, person power?
Person power? Yeah.
Yes, person power. The new word, person power. So meaning resources in manpower. Person power. Sorry, resource, whether we have enough resources.
Oh, okay, I get it. I
Person
get it.
power. Yes, sorry.
I don't understand the question though. If there's enough person power.
Yeah,
to-
can you scale
Yes.
surgical services to meet the need?
To scale lung cancer screening up in a quick fashion.
I mean, you can find enough surgeons to do all this, at least in the United States. I think, I think in other countries, it may be a little difficult to find thoracic surgeons that are trained specifically in this type of, looking at these little nodules and what do you do with them, et cetera. But in the United States, I think there's an overabundance of person power.
Thanks. Thanks. Yeah, one last, maybe we have 3 seconds there. Yeah.
31 seconds.
31.
When you talk about cessation, you tend to complicate it. Ask my wife. She said, between me and the tobacco, that is how I quit it. So, the role your levers have in this topic is very great. Please use it.
Thank you.
Maybe we should change it between me and the CT scan, maybe. But I would like to thank the panel, my co-chair, of course. Thank you very much.